that, I'm really excited to move into our next section, which is the introduction of our guest speaker, Dr. Mike Englesby, who's well known in the University of Michigan community. But for those of you who probably don't know him, he is the director of the Michigan Quality Collaborative Programs here at U of M. We have an umbrella of all of these CQIs that are run out of the University of Michigan Center. He is a transplant surgeon by training, and he also wears the hat of as a director of the Michigan Surgical Quality Collaborative, otherwise known as MSQC, and he co-directs the Michigan Opioid Prescribing and Engagement Network, which we all know as MOPEN. His interests focus on improving quality and implementing best practices, but he also holds key roles in our medical school, teaching medical students, impacting their curriculum, and teaching research science to our surgical residents as well. He also is the professor of the Cyrus D. Darling Senior and Junior Professor of Surgery within the University of Michigan. When he's not performing kidney and liver transplants, and particularly liver transplants in children for pediatrics is just an outstanding accomplishment. So he is an active investigator. He has support through many of outstanding grant sources, including the NIH, CMS, CDC, the Michigan Department of Health and Human Services, as well as Substance Abuse and Mental Health Administration, and of course, Blue Cross Blue Shield of Michigan. So I'm going to turn it over to Mike, who is literally says he aspires to make Michigan the best place to have any kind of surgical care. So we have a lot to learn from him. So today he's going to be speaking about where MEDIC fits within the large structure of the consortium of collaboratives. Welcome, Mike.
Awesome, thank you. Honored to be here. Someone give me a thumbs up. I'm in a lonely conference room. Good. It's an honor to be here. I'm very grateful. I'm a little upset because I've never seen Keith Coker not in like a pullover, looking kind of disheveled. And so I assumed when I dressed for this that I would just kind of dress like Keith Coker and wear like relatively unprofessional clothing. So I apologize. I was trying to fit into the culture of the emergency room. Seems like I have miscalculated. Probably won't be the first time through this talk. Anyway, I assume everyone's laughing now. That was kind of the intention. I'm laughing. So it's an honor, and a couple other disclosures. I do have some ownership stake in a couple companies that have sprouted from my research that I noticed I didn't disclose. I think I did on the CME piece, but I should have a slide for this. One's called eBoo Health. It's around tracking devices we leave in humans. Another one is called PeriOptions. It's a anesthesia-based company around kind of perioperative care. None are relevant to this talk, but it's important that I fully disclose. The title of my talk is kind of how does MEDIC fit into this remarkable kind of resource we have in Michigan called the Collaborative Quality Initiatives. And hopefully you won't find it too boring. Really, my goal is to help you appreciate kind of the remarkable thing that we have in Michigan and how proud we should be of it and what a key part of it that MEDIC plays. And so you can kind of understand how it fits into a relatively big picture on improving health in Michigan. So the CQI portfolio I'll talk about in a bit of detail. And really the vision of it is to deliver high value healthcare change to everyone in Michigan. I think one of the things I'm most proud about the portfolio and the collaboratives, of course, including MEDIC, is that all of our work is focused on every patient. So I think Blue Cross deserves credit for the vision that we serve every patient. We don't just kind of come up with initiatives that kind of serve the Blue Cross patient population. And as a result, I do believe Michigan's the highest quality, lowest cost state in the country for hospital-based care. But we have a lot of work to do in health. So what does that mean? I dichotomize it into like the health care, which we kind of know what that is, surgery, emergency rooms and stuff like that. And we're good at that in Michigan. But I think in the treatment of chronic diseases, the management of chronic diseases, social care, things like that, we are, about national average. And as a result, the people who show up in our emergency rooms are really sick. And how do we leverage the healthcare infrastructure, particularly the portfolio, to kind of try to improve the health of the people that show up in our door, and why that's so important. So there are 24 collaborative programs, and I'm going to actually read them out just so you understand the broad scope of work that is done across the portfolio. So OBI focuses on cesarean section. Marquee focuses on total hip and total knee. Impact focuses on transitions of care, particularly hospital, discharge and transition to nursing home. Music focuses on urology. HBOM is a new CQI. They're actually leading some of the smoking stuff that I think you guys are engaging in, and they focus on health behaviors. MISIC focuses on spine surgery. BMC2 focuses on cardiovascular care, including PCI, TAVR, and vascular surgery. MyBack focuses on back pain. MVC focuses on healthcare value. HMS, hospital-based medicine. MBSC, bariatric surgery and obesity. MCT2D, a new CQI focusing on the management of type 2 diabetes. MOXIE focuses on medical oncologic care. MEDIC, as you know. MPOG and ASPIRE focuses on anesthetic care. MROC, radiation oncology. MSQC, surgical care. MTQIP, trauma care. MACI focuses on the optimal management of anticoagulation. MSTCVS, cardiothoracic surgery. And OPEN, which isn't technically a CQI. It's not directly funded by Blue Cross, but it works with many of us across the portfolio around safe opioid utilization. So this is kind of a big administrative thing, the portfolio. And essentially how it works is it's generally specialty based. Generally, there's a registry that backs it, just like you have in MEDIC. Across the state, there's over 300 full-time staff who work in the portfolios, most of them at Henry Ford or at the University of Michigan, and they get up in the morning and their job is to improve health care in Michigan. They drive the actual work, and they're the kind of the heroes of our impact. We pretty much every hospital and in some way, shape, or form, every physician in the state has some touch related to the CQIs, whether they know it or not. Really, when people ask me what is the job of the CQIs, well, I kind of describe it as this: Blue Cross smartly outsourced their QI and their value kind of agenda to the physician community, just because if regulators or payers try to do these things, it's not very effective. But if emergency room physicians only listen to other emergency room physicians about how to change emergency care, and thus the incentive structures are empowered to the physician community. And I'll talk a little bit about that. And I think I was really excited to hear about the publications committee and all the innovative research that's using this robust platform at MEDIC to really drive new data, new information, and kind of innovate how we deliver care. That happens across the portfolio, and there's a massive research kind of side hustle that is not the goal of the portfolio, but really, everyone in those specialties across the country really benefit. And Michigan is considered kind of like the home of so much great clinical research across the country. So here's a couple, just a very 2 or 3 highlight reels, like what kind of stuff happens across the portfolio. So this is a slide, and I pretty much randomly, I have like literally 300, 400 of these slides, but I randomly picked a couple. MISICs run at Henry Ford, spine surgery. I'm always amazed how some of these groups can get people in the same room, and getting a bunch of spine surgeons in the same room. It's just kind of a remarkable feat. They don't answer, I can't get an appointment for a friend with a spine surgeon. They don't necessarily answer my pages, probably not yours either, but they all come together and they talk about spine surgery and improving it. And they also focus on stuff that really matters to patients and stuff that, a regulator or payer wouldn't really appreciate is important. And this is, urinary retention. And this is you can see the data for reduction in urinary retention after spine surgery in the state of Michigan. I was really interested I've actually never heard of I think the leveling measures or whatever Keith called them. I've actually never heard that term, embarrassingly. I was really inspired that that background work, I'm sure it's very hard to do, is done just to make sure that we're kind of doing no harm in our work. Anyway, BMC2 it's been around for almost 25 years across the state. They focus on PCI, and they do so many remarkable things. They have this culture of trust among the interventional cardiologists in the state, where they share their cases. They watch kind of the films of the actual interventions. They grade each other. They deem interventions appropriate or inappropriate. It's kind of really a remarkable community. And I have no doubt that if you need kind of coronary interventions in our state, that across the board, it's the best in the country. And here's some of their accomplishments in a slide. Another one is related to open in the MSQC. So, and this is around opioid prescribing. So this slide shows kind of time on the bottom, and then there's 4 bars. So an intentional effort was made to develop opioid prescribing guidelines across surgery. And I know a lot about this topic, and I actually learned that the emergency room was like kind of 5 years ahead of everyone else in how they manage opioid prescribing in the emergency room. And I think it's just emblematic that in the emergency room, you kind of see what the real problems are, really real time and before anyone else. And the rest of us kind of, don't appreciate it until lots of papers are written or lots of data is collected. So anyway, this is kind of a 2, as you can see, with guidelines being from about 30 pills after surgery. We're actually down around about less than 2 pills for the average operation in the state of Michigan, which is pretty remarkable. And patient satisfaction has not budged. Patient pain has not budged, and patients are taking fewer and fewer of the pills that we consume. And what's really cool is if we compare ourselves to other states, and this is kind of, I think, demonstrates the power of the portfolio. And this is all surgery. So Open worked with pretty much all the surgical collaboratives, and this is the number of pills prescribed after surgery. Time is on the bottom. Michigan is yellow with air bars. So you can kind of see how quickly it came down in Michigan. These are kind of other states. I think there's 5 of them. It's like Kentucky, Ohio, Wisconsin. So the states that kind of touch Michigan were high prescribers. You can kind of see how quickly Michigan and how nimbly Michigan kind of drive change in practice, unlike other states. I think I know that is related to the remarkable portfolio within which we work, and we should be proud of that. So that's clinical data. And I could sit here and just kind of give you highlights all day. But, I think a lot about healthcare and healthcare delivery. And I think this is a great report if you're a nerd and you like to think about kind of healthcare payment and stuff. It's a RAND report. And essentially the purchasers of healthcare in Indiana asked RAND to study the prices of healthcare across all the country, all the states in the United States, and only 25 states kind of had data where you could actually do this. So what this slide shows is the Medicare kind of payment rate is down here at 1, and then private payers, pay more than Medicare. So, and it depends on which state you live in, what that kind of rate is and how much the costs are. So in Michigan, it's about 1.6. So we get paid, $1.60 for someone comes to the emergency room, and this is not specifically true, but in general, if you do the same care on a bunch of Medicare patients and a bunch of Blue Cross patients, you get paid $1.60 for the Blue Cross patients and $1 for the Medicare patients, at a population level. And you can kind of see up here where it's almost, twice as much in other states. So Michigan is the lowest cost state in the country for private payers, and Medicaid and Medicare payments are pretty much flat across the country. So Michigan's, from a healthcare perspective, is a uniquely inexpensive and a very high quality place for care. And we do amazing work. This is not all just because of the CQIs. There's all kinds of market forces that I don't really understand. And also, there's an evil dark side to everything. It's not necessarily an easy place to be a health system or a CEO of a hospital because our payments are lower. But nonetheless, it's kind of funny. I was in not South Bend, somewhere in Indiana, volleyball tournament, teenage kids. And I had like 5 hours truly with nothing to do. And I didn't want to be in a room. This was like second week of January with 2,500 Midwestern parents, of which only my daughter and I had a mask on. So there's a hospital like a mile down the road, and I just kind of went in. I'm like, if they're getting paid twice as much money as us, are things really nice in this little hospital? It wasn't Fort something. I don't know. Anyway, the hospital was really nice. They had really nice things. I kind of felt like I was in Las Vegas, and I was like, wow, maybe they do get paid twice as much money as we do in Michigan for healthcare. So this is, I'm going to turn and focus on Medic a bit. So this is some summary stuff. I will not go through this, but it just impresses me so much how quickly Medic has turned into having an impact on people in the state of Michigan. It's such hard work for everyone to drive change and to change any physician's practice. I think particularly in the emergency room because of just how frenetic the pace of the work is. And this is kind of a summary slide, and I'm just kind of proud to be associated with it and the people whose lives have been improved. My father is a healthy 80-year-old guy, and he got an inappropriate head CT related to, actually not a head trauma, but they did some head CT for some cockamamie reason. He lives in Florida. And he proceeded to then get an MRI and a PET scan. The whole time he's like, when you're 82 and they're doing all this x-rays, they're going to find something, aren't they? And I was like, yeah, they are. So he ended up having to, it was very stressful for my family. And that all started with an inappropriate CT scan. And so that's the impact on patients is really impressive. So kind of how does Medic fit into this whole thing? Well, a couple things. The portfolio is more and more trying to use its resources to focus on health equity. And Medic is actually the first CQI where I heard the words health equity used. And I think it's just because of the nature of the frontline work that you do. I would be remiss not to call out the disruption and the remarkable work of everyone on this call around COVID. As a transplant surgeon, my life largely has not changed outside of my personal life. But clinically, it's kind of the same old, but I can only imagine how driving practice change through the overwhelming kind of impact of COVID. Everyone should be very proud. So thank you for your work. We have 24 collaborative programs, and Medic is the only one that focuses any of their work on children, which is kind of a disgrace, to be honest. And we'll try to remediate that in the future, but nonetheless, it's humbling and brilliant that was part of the initiative as it started. And we will try to do better going forward for these kind of the most important people that we care for. I kind of thought when Keith and Michelle started Medic, it was kind of silly to start focusing primarily on the appropriateness of care because there's only one or two other collaboratives that really do that. Most of them just focus on outcomes, and it's so very hard to do. And the fact that you've pulled it off is remarkable. Appropriateness in healthcare is rarely studied. It's rarely measured. And I think it's just inspired that that's the approach you've taken to improve care. I'm very excited about the cardiac care work that you're just starting across Medic. I think there's lots of opportunities across the whole state, and also humbled that when we're trying to do something around smoking cessation across the entire state, that I didn't expect Medic to volunteer. I don't really see how things like smoking cessation fit into the emergency room care, but that having said, I haven't really been in an emergency room in 15 years. So maybe, so your ability to just hop on and be great partners and say, sure, we can give anything a try. And just humbling. So thank you so very much. And this is just a slide of some of the Narcan distribution work that's been done through Medic in partnership with Open. I think when I'm going to talk a little bit more about population health and foundation health in the state and how we can all do better. And we have to pick our spots. I think in emergency medicine, take things like this to prevent kind of overdose, and the Suboxone work that's been done to link people to resources around opioid overdose is just remarkable. So I do a lot of stuff with medical students, and this is like, I dug up an old email of one of my favorite medical students from think about 4 months ago. And she said, I'm going to the emergency room because that's where the real problems are. I was trying to, I was like, you should be a transplant surgeon. It's so cool. And I think that's kind of, I think that's humbling. And the next part of this may seem a little bit of a distraction, but think about, you have all the doctors and all the physician organizations and all the hospitals, and we're trying to like use it, nudge it towards improving kind of health in Michigan. And I say health intentionally, not healthcare, because health in Michigan stinks. So this is a slide from The Economist showing it's data is kind of old, but survival, and we all know these data, survival in the United States continues to go down, particularly for our most vulnerable members of our society. And we have this paper in the surgical collaborative where we basically measured kind of like where in colon surgery in Michigan, where we've been working on improving for 10 years, colon surgery is super high quality. So you get to a point where all the surgeons do a good job, all the hospitals do a good job. So pretty much all the risk is about who you operate on. And 45% of the risk is on the patient. 48% of it is essentially random variation. And only 2 or 3% are around the processes of care at hospitals or surgeons. So, it's always hard to tell surgeons they don't matter very much. But really the point is that on the people who we care for, really determine a lot of the clinical quality outcomes that we achieve. And we need to focus some of our resources on trying to make the population healthier. So how are we doing that? One is the new CQIs that we're investing in focus on health equity, health behavior, and health prevention. So diabetes is the first big one. There'll be a lung disease one that will have a pediatric focus also that is coming on board soon. And I'll talk a little bit about health equity and health behaviors. But really the way I think about kind of my role as a surgeon is kind of like this. So this is not a real patient. I found it off the internet, but this lady comes in, say, to your emergency room. She has right upper quadrant pain. And you diagnose her with acute cholecystitis, give her some antibiotics, admit her to the surgical service. I see her the next day. I add her on at my convenience, maybe that day. Take out her gallbladder. She goes home the next day. All very efficient. She's in the hospital 36 hours. She may follow up with me with a video visit. She's happy. Everyone's happy. And we get through the healthcare system very efficiently. Kind of the problem is that the system I work in is designed to intentionally almost avoid most of the problems that really will affect her long-term survival. So it's really, the focus of my care is kind of this technical endeavor. And I put the slide up here because the anatomy is all wrong. I don't even know what the Rouvel sulcus is, and I'm a liver surgeon, and I don't know what S4 is. But nonetheless, and the common bile duct actually goes this direction. But my kind of job is to take out her gallbladder and send her home. But if this woman comes in with obesity, she comes in with smoking, that will make her live upwards of 18 years less long than if she didn't have those health behavior risk factors, let alone her ability to get transportation to healthcare, et cetera. So, and this is one of my favorite slides. I didn't put a reference in here, but it's pretty well known. I think Schroeder, New England Journal of Medicine, 2002, I believe, is where it comes from. But if you kind of measure what affects someone's longevity, clinical care ranges between 10 and 20% and physical environment. The majority of it is health behaviors and kind of social determinants of health. We all know this intuitively. We need to use some of our precious resources in the portfolio to focus on population health, because that requires us to make programs around racial equity and health behaviors. We're going to start doing this. I have no idea how this fits in to Medic, other than I'm impressed you're dipping your toe into some smoking cessation. I'm excited to follow along with what you want to try to do in health equity. I think you probably have a unique sense of community-based care and kind of what happens kind of outside the doors within the neighborhoods that you serve. And there's probably, we do not invest very much at all in community-based care in the state of Michigan. About 99% of our money is spent on hospitals and doctors' offices, very little within communities where a lot of this work will need to happen. But to try to start to move the portfolio in that direction, we have two new groups. One is called M-Shield. I won't read kind of what they're trying to accomplish, but they are experts in social care, social determinants of health, health equity, all of the things that underlie probably the majority of the kind of health problems of the patients who come into your emergency rooms. And if we can leverage some of the fancy buildings we work in just to nudge this in the right direction, because I think the doctors are poised. They just need to know, it's easy to write a prescription for amoxicillin, but it's really hard to link someone to kind of stable housing. And then health behaviors. So if I do a liver transplant on someone, I make them live an extra 6 years. If I get them to quit smoking, they live an extra 7. One of them costs $1 million, the other one doesn't. So we obviously do not invest much within our healthcare system around health behaviors, and they're hard to change. But, we perioperatively, we've nudged our smoking cessation rate up from 8% upwards to 35%, just at our own institution, just by trying a little bit. And it's exciting work. And along smoking, nutrition, many other things. About 2% of the people who have elective surgery in our organization have food insecurity. And linking them to kind of resources, at least perioperatively, is something that we definitely can do. Incentives. I probably know more about Blue Cross incentives than any person except people that work at Blue Cross. So I'm mostly putting this up here as a placeholder. If you want to ask me questions about these, I will. Incentives, Blue Cross incentives are very, very large compared to other incentives from Medicaid, other incentives from Medicare within your organizations you work. Incentives cannot change individual physician or nurse behavior. Physicians almost resent them. Doctors should never expect that any of this money will trickle down to them or their programs. I've tried that enough times that I've always basically failed. It goes into a pot of money. But nonetheless, what incentives can do is one is you can try to figure out how much incentive money is flowing through the work you do. So smoking cessation, University of Michigan, $550,000 across the CQIs who are going to engage in smoking cessation. It's like, all right, that's money. I can take that number and motivate a meeting. So people can come to a boardroom and talk about smoking cessation, and then we can have a real discussion around some return on investment for an organization. I think that's how the incentives work. They can get all of us in a room together and talk about improving care. So incentives 101, I think you guys may understand this better than the other CQIs, but there's hospital-based incentives, and then there's the VBR, physician organization-based incentives. Every hospital, every emergency room group has a different kind of calculus on how this all works, but it's a lot of money. It's in the many hundreds of millions of dollars across the state. So where are the CQIs going next? Well, I talked a lot about kind of trying to prevent illness or prevent the progression of illness, health equity, health behaviors. But there's some other areas where we have gaps and we aspire to expand. One is intentional QI around nursing care. Nurses drive most of the QI, but most of it is kind of like physician-centered or patient-centered. Patient-centered, good, physician-centered, needs to be more intentional to partner with the nursing care. Long-term cancer outcomes, critical. More and more work with at-risk populations, community engagement, payment policy, new technologies, expanding more of our resources into the women and children, patient-centered work, and then mental health. There is I didn't put it up there, there's a new CQI that's getting launched imminently around suicide prevention, which is very exciting. So the vision of the portfolio is to deliver high value change that improves the overall health in the state of Michigan. I'm so proud to be here. I'm so impressed with the remarkable work that is happening across Medic, and it's humbling. And I appreciate the opportunity to talk. I'm available for questions.
Hey, Mike. I'm pretty sure based on your comments that I can wear a hoodie the next time I talk to some surgeons. Is that fair?
I mean, I didn't think you owned any dress clothes. Like maybe when you got married 15 years ago. But.
True. Any questions? I certainly have some myself, but want to start with the group if there are any out there. And it's certainly possible, Mike, that you just stun them all into silence too with your insights and
stun them into
understanding of how actually the ED works.
Stun them into fatigue. They're sleeping under their desks. So
unlikely. Well, I'll start. I mean, I appreciate that you really have, I think, a lot of insight here into how Blue Cross strategically is thinking about value partnerships and CQIs. And I wonder if you could comment a bit about your take on sort of the health of the programs, the longevity of the programs.
Yeah, sure. So the CQI portfolio is kind of expanded in fits and starts, and we just went through an expansion phase over the past year. So the first one started 25 years ago, and then for a long time, we had 17 programs across the state. And then last year, we launched 5 or 6 new ones. I think they're the foundation of how Blue Cross engages physicians and hospitals. I think they are viewed with a lot of pride for the Blue Cross team for good reason. This is really their brainchild. Them and a couple kind of key physicians from across the state in the distant past. The resources are robust, and how it links to incentives for the physicians and the hospitals continues to be ingrained in our work. So to answer your question, I think the CQIs are alive and well, and they continue to expand. The pressure on the CQI portfolio is the same thing as the pressure on every health system in the state, where more and more consolidation of healthcare systems and large systems are going to look inward. And that really does threaten our ability to collaborate as a group. So what does that mean? They instead of looking at statewide data and engaging across the state around improvement and best practices, it becomes more and more, when you have like a 7 hospital network, that you make your own little collaborative groups across your network. The data on that nationally is that it accomplishes one thing: it drives up costs. So I think that's an exposure and a risk that we've been a little less exposed to in Michigan for various reasons, but I think that is a threat. It's a threat to the high quality, high quality, low cost care that we deliver in Michigan. But the competition is real, and I think, and this is a bias, I don't have data for this, if you let the physicians drive the care improvements, then that is how the patients benefit. If it becomes essentially done by executives who are well-intentioned, but they're focusing on the health of their own system, that consistently drives up costs. And then the measures disempowers the physicians to really inform kind of how to transform care. That was a little bit of a rant. So I think there's some good news and some bad news. The good news, I think we can continue to affect when we essentially explain to everyone the value proposition of the portfolio. That's our role, I think, to a certain degree. And you, Michelle and Andy, have done an amazing job of that. The bad news is stuff that's probably out of our control as physicians and nurses in the state of Michigan. And I think that's frustrating for all of us.
Yeah, thanks. Questions that might have come in their interim for my team?
Nope, none at this time.
All right. Well, why don't we stop there? I mean, we have some more things to get to. Want to be knowledgeable of your time, and really appreciate you, Mike, coming on and giving us some higher level view of these programs and how Medic fits into all of that. So thanks so much. Thanks for being an advocate for us in this work. Really appreciate it.
Honor and a pleasure.